produce substances. That's like a big difference between the virus and like a protein. Still, we don't know a lot about the COVID vaccine. We have the COVID virus. We have a lot of viruses that we know a lot more about, for example, like the HIV. But it's still like a topic of research.
All right. Thank you. Now, in terms of the spreads and stuff, how is it spread and what is community spread? And I'm hoping that it could be in layman's terms for the basic man, woman, child to understand. So I could take it back to you, Dr. Moses.
Yeah, so how it's spread is it's spread. In the beginning, when we didn't know much about it, there were a lot of different theories about like touching. But what we have found out over like the last couple of months is that the greatest route of spread is through respiratory droplets. So you cough, and you produce like saliva droplets, or you sneeze and you produce saliva droplets, and that goes to like another person. That is like the main way that COVID is like transmitted. To a lesser degree, you could also have like touching surfaces because the COVID virus stays around for quite a long time if the surfaces are not sanitized. So, for example, if I sneeze on this table right here, and like within the next like 2-3 hours, another person comes and like touch this table and like scratch their nose, that's like potentially another way that it could be spread. But the main way is through droplet contact, and that's why masks are so important in the fight against COVID.
Okay, thank you. Now, Mistress Belfon Louison. Now we hear about community spread, and can you explain to the people what is community spread?
Yeah, sure. And can you hear me well?
Yeah, we can.
Okay, great. So community spread is sort of the phase in the spread of a virus when we can't necessarily trace it back to one individual, right? So if, I think a lot throughout the pandemic, in Grenada in particular, the cases that were coming up, it was possible to trace them back to sort of like the case zero, right? And then once you get to a point where someone can't necessarily pinpoint, or like government officials can't necessarily pinpoint where the source is, then we say that we have community spread because it's pretty much everywhere. And obviously you can use data to look and see if there are areas where there is more spread than other areas, but generally you can't necessarily say, okay, person A spread this to person B to person C, and then be able to contain it. So that's the main thing, like not being able to identify a source, but then on top of that, not being able to contain the virus as effectively as we saw like early on in the pandemic in Grenada. We were able to contain it because we were able to isolate people. We knew where the cases came from, and that sort of like was able to stop the spread. But now it's coming from all number of people within the community, so it's a little bit harder to contain, and so we have to use a lot of different mitigation efforts.
All right, thanks. Now we hear about prevention. How can I protect myself? Should I use soap and water, or always search for a hand sanitizer? And what should a hand sanitizer contain?
Are you sticking with me?
Yeah. Yeah.
You want me to take that, Keston?
Yeah.
So you want a hand sanitizer that is okay. We want a hand sanitizer that's like at least 70% alcohol, has at least 70% alcohol, just so that it's really effective in killing the virus. Right. And in terms of protecting ourselves, I think, there's the basics that I think all of us, especially us Grenadians, like, we're very good about like washing our hands and making sure that, our surroundings and ourselves are clean. But on top of that, I think, since like March, April of last year, we've all learned so much about masking. And I know when I have been home, the couple of times I've been home since, generally people are pretty good about that. So I really encourage people to continue to do that. As the Dr. Moses who spoke before me said, the masks are really important because this is being spread by our respiratory droplets. And that could come about from us talking, breathing, sneezing, coughing. So wearing a mask is important to protect others, right? If you happen to be infected, but also to protect yourself, because a lot of studies, we weren't sure in the beginning, but studies have shown and confirmed that, the masks can also be protective to the individuals wearing them because the way the virus enters our bodies is, through our nose, through our mouths. And so being able to protect that as much as possible is really ideal. Now, so that's sort of like baseline line of defense, right? But then on top of that, we want to make sure that we say social distancing. I like to say physical distancing because we can still be social, but we need to make sure to maintain that physical distance. And so you want to wear your mask. But then you want to physically distance. And when you think about physical distancing, it's not only if I am in a room with individuals, I want to stay at least 6 feet away from them. I should, right? And I should be wearing my mask. But on top of that, I should be thinking very carefully about where I'm going. Do I actually need to leave the house? Do I need to be in this enclosed space? I know it's really tough. I live in New York City, so I was under quarantine for a long time. So I know that it gets really tough, but I think really being thoughtful about who you're sharing space with and whether you need to go to X place or Y place is also a huge part of physical distancing. In addition to once you are around people who you don't necessarily live with, you want to make sure that you're staying at least 6 feet away from them because again, it spreads from the droplets. So if you're away from the droplets aren't going to get to your nose, they aren't going to get to your mouth to infect you.
All right, thank you for that. Dr. Lambert, considering in Grenada that we live pretty close to each other in a house, you'll probably get 4 or 5 persons. All right, what should I do if I get sick or someone in the house gets sick with COVID, and what recommendations you have for someone who has symptoms? Because you hear people saying that they get different advice from persons, whether they should go to a health center and they're at home, but they don't know how to self-isolate. So, what should I do if I become infected with COVID-19 at home or someone in my house becomes infected with COVID-19?
I think as the previous Dr. Belfon has been pointing out, the absolute safest thing to do if you have the space is to get that person within a room for themselves and to allow them to have a confined space where they can eat and not share a bathroom, not a toilet or anything else, utensils, whatever the case you may have. But I understand the limitations in doing that, and that's actually quite a convenient thing to have because in some places, for example, if we looked at what happened when the pandemic started in Europe, in most European countries, for example, in Italy, a lot of people were living in close quarters with each other. Old and young were living together, right? Rich and poor were right next to each other. So if you can't really, if it's not actually possible to isolate from someone, the only other measures you can possibly do is by using a mask, for example. So if you have a 2-bedroom house and it's not possible, 5 people in the house, then you run the risk of having an infection. The other things that you can possibly try to do is getting ventilation as much as possible, having as much space even within close quarters. Because I think what the new research has shown is that if we're gonna be inside, we at least try to maintain that physical distance or social distance, whatever you want to call it. You at least try to maintain the proper hand hygiene, and you at least also try to cover your face with at least one of the disposable masks, because you probably won't get FFP3 inside the house, but you at least try to employ those measures if you're limited with space. So you would employ precisely the same measures that you would have done outside with unfamiliar people. You would then just employ the same sort of standards in your household.
All right, thank you. Dr.
I
Mackenzie.
totally agree with Sean. But if you have the heart, you just put them outside. That was just a joke, okay? Sorry.
That's okay. Dr. Mackenzie.
Actually, I'm sorry. Before we go on, to add to Dr. Lambert's point, you made some very good points about the social distancing and the physical distancing. But what we, in terms of being at home versus requirement to be hospitalized, what a lot of places do is that they base it based on your severity of symptoms. And you know, of course, we'll have to go through the symptoms of COVID soon. But the most common symptoms, of course, are cough, which is in about 50% of people, dyspnea, meaning shortness of breath, which is in about 43% of people. And a lot of people get upset because they say, you know, listen, I can't get hospitalized. I want to go to the hospital. I don't feel well. The people that really need to get hospitalized are the people that have moderate or severe dyspnea, or moderate or severe shortness of breath. And how you can assess yourself or assess your shortness of breath at home is really asking yourself some questions like, what were the activities you could do before being exposed to COVID versus now? So if before, you know, you could get up out of bed, go downstairs or upstairs, you know, make yourself breakfast, or go for a long walk or walk from your home to the bus station or whatever, and you never had symptoms before, but now you're having those symptoms, that's a red flag. Then you should, you know, reach out to the medical professional. But if you're not having those symptoms, you're okay to stay home and, of course, do the physical distancing, as Dr. Lambert discussed. Oh, another thing, in addition to shortness of breath, dizziness. Dizziness tends to be a sign of hypoxemia, meaning low oxygen in the blood. So if you start having dizziness, mental fogging, you know, confusion, in addition to the shortness of breath, that's a sign that you should probably reach out to a physician. But if you're not having those signs and you've been exposed to COVID and you're just having the cough, the mild fever, and so forth, you're okay to stay home and physically distance, wear your mask, and so forth.
In addition to what Dr. Mackenzie was saying, when it comes to what's that?
Go ahead.
When it comes to shortness of breath, there is a lot of subjectivity to it. Anxiety among patients adds to the feeling of being short of breath. Being in the ER, about like 30% of the patients who come in, they come in because they're short of breath. And you go into the room and they don't look like they're working to breathe, and you put an oxygen monitor on them, and the O2 saturation is above like 94%. Like those patients, I'm not too like concerned. So if you have the opportunity to be assessed by a medical profession and they deem you not at serious risk, and you're still experiencing that sort of like subjective shortness of breath, what you should do is use that symptom as a baseline. And when you go back home, if things start getting worse compared to how you were feeling when they initially evaluated you, that might be a cue that you may need to be reevaluated. I'm not sure what sort of access we have to those pulse ox. It's like a little machine you put on your finger. Like up here in the US, you could get it in a pharmacy. A lot of times to tell my patients, you know, you could grab one at Walgreens, Walmart, and sort of like monitor your oxygen saturation at home. Usually for like COVID patients, if you're like healthy above like 94%, 93%, I'm cool with that. When you start dipping to like 90, 89%, that's when a thing is problematic.
All right, thanks. Now, this was covering the basics, right? And then I've seen a lot of questions in the chat, which I would like to get to. But before I go on, I want to address Dr. Mackenzie. You're a hematologist. So for the viewers, I'd like you to explain what that is. What is hematology? What do you do? And well, hematology in relation to complications of COVID-19 infections.
Yeah, so I'm board certified in internal medicine, hematology, and medical oncology. So what we are seeing with COVID-19 is actually a lot of hematologic manifestations. And I'll give you an example. Some of the most common hematologic manifestations of COVID-19 is an increased risk of blood clots. Both the venous blood clots, and venous blood clots meaning, you know, blood clot in your leg, you know, blood clot in your lung, also known as a pulmonary emboli. But we're also seeing an increased risk of, you know, heart attacks and strokes in addition to just the regular blood clots. And what we're seeing, what the data currently shows, is that in patients who are hospitalized from COVID-19, about a third of them get some type of blood clot. And patients who have severe COVID-19 that develop sepsis, that sepsis can actually affect or suppress the bone marrow. So these patients can not only get blood clots, but they could also have very low platelet counts, which increases the risk of bleeding. Now, one of the big concerns that people have is saying, oh, well, doc, I hear the vaccine causes blood clots too. And that's a fair concern. That's a fair concern. But what the data has also shown, let's say the Pfizer, for instance, and AstraZeneca vaccine, the chance of getting a blood clot from that is 3 in a million. Now, Mamat's not the best, but I think that's like 0.00003%, so probably like 5 zeros after the % risk of getting it from the vaccine. Compared to if you get COVID and you get hospitalized, we're looking at like 33%. And I think that's a risk that probably translates to maybe at 10,000 times the risk. So that's something we see. In terms of blood clots and strokes and heart attacks, as a hematologist, what I have noticed is that I'm getting a lot of patients who have no other high-risk features, no diabetes, hypertension, over obesity or anything like that. And then they're coming with strokes, like in their 30s, 40s, coming with strokes with nothing else. And these things are a side effect of the COVID-19 virus, the COVID-19 infection. And these are the things that people need to be aware of.
Okay. Thanks. Now, I want to get to some of the questions I have. And the first one, I want to address it to Mistress Belfon Louison. Now, someone asked, if you are a breastfeeding mother, can you take the vaccine?
Yes, so all of the American College of Gynecologists and Obstetricians in the U.S., as well as the CDC in the U.S., as well as some bodies in the U.K., do recommend taking the vaccine while breastfeeding, taking the vaccine while pregnant. Early on, pregnant people were not included in the clinical trials. So early on, we were not necessarily sure how the vaccine could potentially affect pregnancy. But now there's a lot of data showing that there is no risk of becoming vaccinated while you're pregnant, or risk of not becoming pregnant after a vaccination. And also there's no risk when you're breastfeeding. I think in addition to that, one of the benefits of getting vaccinated while you're breastfeeding is the potential to pass the antibodies on to your baby that you are breastfeeding. And the studies that I'm citing have looked at thousands of women. I always tell people that I'm an N of 1, and as an analyst, we like lots more numbers. But I think people's own stories is also important. And I personally am currently 9 months pregnant and was vaccinated during my pregnancy in my first trimester. And we're gonna knock on wood, but it has been a healthy and uneventful pregnancy so far. And one of the things that motivated me is the fact that I could pass antibodies on to my baby once they are here. And I think that's really important since children under 12 cannot get vaccinated. So said all of that to say, yes, please, if you are thinking of becoming vaccinated, please don't not do it because you're breastfeeding.
In addition to what Cassie was saying, on the contrary of not getting vaccinated while you're pregnant, there have been reported cases, and I've seen that firsthand, where you have mothers unvaccinated who contracted COVID while they were pregnant, and they ended up having a stillbirth and sometimes death of the mother themselves. So the risk is like way, way higher of you not getting vaccinated than getting vaccinated in the pregnancy state.
Thank you so much. That is a very good point. That was one of my motivating factors as well. Yes, there's so and that was back in February. Now there's been more studies that have come out, and it really, is an increased risk for not only the babies but for the pregnant people as well. So yeah, that is a really important reason to be vaccinated if you are pregnant.
All right, thank you. All right, Dr. Moses. When we talk about children now we see children getting sick with COVID-19. What are the rates though? What are the percentage in relation to children getting sick with COVID-19? And I've read something about a multi-inflammatory respiratory syndrome in children. Now, what is the likelihood of that happening after being infected with COVID, with kids being infected with COVID-19?
I don't think I'm fully understanding the question. Is it like how sick pediatric patients? No, we're seeing that kids can contract COVID. They're saying that it's more now, right? So, yeah, go ahead. Sorry. So, like in the beginning, in the beginning of the pandemic, it was like mostly like adults and like older people. We were hardly seeing any kids. Like now we're seeing like more kids contracting the virus, but it still stands that most kids who contract the virus, they're usually like less sick, usually like have like less respiratory symptoms, usually like have less of an inflammatory response. So whereas like the adults will feel like shitty, the kids are usually like doing like backflips. On the flip side, when you work like in developed countries, you have like a lot of kids with underlying conditions like type 1 diabetes and like obesity. Like those sort of kids, it hits them hard.
Okay. All right, thanks. Now, another question that someone asked, Dr. Lambert. They're saying that the vaccine are in the trial stages until 2023. Why should they take the vaccine?
Well, there's a mountain of evidence that suggests that the vaccine is good. I can give you, we can look at actual studies that have suggested that, for example, and we can also look at raw statistics. If we look at what happened, there was a study that was published in the New York Times, for example, and it looked at states in the Northeast. I think they looked at Maine and Massachusetts. They had a vaccination rate at about somewhere between 65 to 67% versus southern states like Alabama, Arkansas, Louisiana, who had a vaccination rate somewhere between 33 and 35%. And the rate of hospitalization was significantly higher in those areas. All right. So that was just basically statistics from an article. In the UK, we have the Office of National Statistics, and it looked at basically 52,000 persons who died of COVID-19 from the period of the beginning of January to July. And 37.9% of those people were completely unvaccinated. Those who were vaccinated had 2 doses and over 21 days of vaccination had a fatality rate of less than 1%, exactly 0.8%. And so the numbers are kind of stacked heavily in favor of. I mean, we can talk about other studies, such as from the New England Journal of Medicine as well. They published something, as well as the CDC published something in this July, which suggested that you have a risk of hospitalization of 25 risk higher if you're unvaccinated, and the risk of hospitalization and death. So there's a mountain of evidence. And the last one, which was one of the most recent studies that was conducted over 50,000 people at Imperial College in London, it's called the REACT-1 study. People who are double vaccinated are less likely to test positive and have 5 times the reduced 50 to 60% chance less or reduced chances of contracting the virus and going on to develop severe illness. So there's so much evidence that suggests that even though a lot of the vaccines has been in a trial phase, and that's kind of been in a cover that a lot of people have been using to say, well, I'm not going to take a vaccine because it's in a trial phase. But realistically, if you look at most of the studies that have been shown, all of it, and we're not talking about 1 or 2 people. We're talking about, in the UK, for example, we have literally over 40 million people who've been double vaccinated, and the hospitalization rates have plummeted. So we're seeing a lot of evidence to suggest that vaccination is significantly better for people who decide to get vaccinated, irrespective of which vaccine you're going to take. If you're going to take the AstraZeneca or the Pfizer, they both have significant benefits.
Thank you. Dr. Mackenzie.
And just to that point, real quick, I'm sorry, just to Dr. Lambert's point, I think a lot of people ask this question, Doc, I get the vaccine, can I still get COVID after I got the vaccine? And yes, you can. However, picking back off the data that Dr. Lambert mentioned, there's also studies that show that if you're unvaccinated, so you didn't get the vaccine, your risk of getting severe COVID-19, meaning that you require hospitalization or ICU admission, was 29 times that higher of someone who was vaccinated. So let's just put that into perspective. And just put that into perspective as the number of people who were going to get hospitalized, the number of people who are going to take up hospital beds in the hospital, the number of people who are going to take away rooms from people with sickle cell crisis, diabetes, hypertensive emergency. We have to think about these things. The problem with COVID-19 is not just COVID-19, but it's the consequences of COVID-19. It's a ripple effect. If you have the whole first floor in the hospital taken up by COVID-19 patients, what happened to the person who struggling with blood sugar? What happened with the person who's struggling with high blood pressure? What happened to the guy, that got cut or developed has an infected wound? Or the person with asthma? These are the people that are not going to get into space. So these people, they may not die from COVID, but they may die as a result of COVID, and we have to keep that in mind.
And that's a very good point, because I think the study that I spoke about initially, the one from the New England Journal of Medicine, which was published on the 12th of August, it doesn't suggest that COVID, the vaccines themselves were designed to reduce you contracting the virus. So there's definitely more data that suggests there's moderate reduction in the efficacy of mild to moderate disease. But there is high efficacy in developing severe disease and mortality. So that's exactly what it was designed for. And that's what a lot of the trials that were conducted by particularly Pfizer and AstraZeneca. There was about one case from the Pfizer study, for example, that actually went on to develop severe COVID during the phase 3 trials of the vaccine. So it actually is reflecting a lot of the statistics that we're seeing now is actually reflected in what was done in the clinical stage of the trials, and it's what has been actually reflected in the studies that have been published so far.
Can I also add something?
No, go ahead.
Sorry. So, yes, really, really great points. But I just wanted to emphasize something from the question, because I think a lot of the times I see people say the vaccines are in a trial phase. And I think what that sort of implies is that they're still being tested, and so we don't know if they're effective. And the trials have multiple phases, and the reason why they're going till 2023 is because that is going to be phase 4, which is typical of clinical trials, where after you've been in phase 3, which is like the most people that you have, tens of thousands of people, then you want to make sure that you're monitoring this after the fact for safety reasons, right? And this is just like, dotting your I's and crossing your T's. It's really just making sure that it's really just making sure that we, at the end of the day, know that these things are 100% as safe as possible. It's not because we're not sure if they're safe. We already are sure on the safety, right? So I think I just wanted to make that clear, that the FDA and these regulatory bodies have like a designated time frame by which they are comfortable with having enough follow-up data before they say the vaccines are safe. Think what's beyond that is just gathering more and more data to be even more sure, to put it that way.
And the Pfizer vaccine is fully FDA approved, guys. The Pfizer vaccine is fully FDA approved, and the Pfizer vaccine is available in Grenada. So there's that. So if you say, the vaccine is being researched, well, the Pfizer vaccine is approved. Let's just put that into perspective. Okay,
so let me bring this then. All right, that we're talking about the efficacy of vaccine, and that you have it reduces serious hospitalization. You don't get severe symptoms let's look at Israel, who now they have one of the highest cases of hospitalizations right now, and they probably had all the adult population or everyone who were liable to be vaccinated. What happened there then?
So that case that you're talking about with Israel, that was a study that was published recently, yes. And they attributed that to mutations more so because as we know, most of the symptoms that we're seeing now and most of the cases that we're seeing now, we kind of moved on from what we have. We have got the Delta variant now. So most of the things that were conducted earlier on with COVID was from an ancestral strain. So like the Alpha strain, the Beta strain. So we're seeing now more things from the Epsilon and Delta strains, right? But that study as well in Israel, what it did say, which was actually quite good, and it was actually supported by another study in the UK, which they call a Strasbourg cohort. And it actually said that, yes, people who are getting more infected and their hospitalization rates were actually higher. But what they didn't mention was the added benefit of vaccination. The people who actually contracted COVID and were vaccinated, or at least had one shot of either the Pfizer or AstraZeneca vaccine, I think Moderna was part of that study as well. But it actually showed that the ED50, which is essentially the point at which you get an immune response that is significant enough to protect you from severe COVID, was quite high. So it actually showed that people who had innate immunity from previous strains and had a dose of the vaccine, even though you've been hospitalized, you should not get to the point of fatality. So it was due to the fact that the mutations with the Delta strain were showing symptoms to be a bit different. For example, with the early strains, we saw that the infections were announced, we saw not smelling properly, not tasting, coughing. With the new strains, of the Delta strains, we found that the symptoms that we have seen are more sort of upper respiratory symptoms. So you get the typical viral prodrome of runny eyes, a sore throat. Still get the feeling of being a bit groggy, but feeling a bit more bunged up, all right? And then it kind of progressed to going down towards your lungs. But it's not a reason to suggest that you shouldn't be vaccinated. In fact, that study suggested even more so that you should be vaccinated, particularly as how this strain is quite different from the other ones.
And if you don't mind, I just want to add to Dr. Lambert's point. So the Israel thing, that's a dark horse because everyone is saying, Israel is an example of how the vaccines are failing. And it's actually quite the opposite. If you look at the data, the people who are getting ill in Israel, right? So let's say Israel had like over 70% vaccination rate, and the people who are getting ill in Israel, 50% of the people who are getting sick and hospitalized in Israel, 50% of the people who are getting sick and hospitalized are unvaccinated. Okay, let's put that into perspective. And the people who are dying in Israel who are vaccinated are the people who have what we will call severe comorbidities, COPD, older, cancer, COPD meaning lung disorder, horrible comorbidities such as diabetes, hypertension, and so forth. When you look at the people who are getting vaccinated, that cohort is disproportionately represented in the people who are being hospitalized. Whereas if you look at the unvaccinated people in Israel, they're younger, healthier, but they're still dying for COVID vaccine. So that's something that, when you report about Israel, you have to kind of look into the data. And even though, yes, there is more people getting hospitalized, the majority of the people who are struggling, are the unvaccinated, and they make up the minority of the population. Just wanted to say that.
And I also want to add too, just really quickly, in like the importance of the nuance of the data. Like Israel also has a very young population, so a lot of whom are not eligible to be vaccinated, which also helped with the spreading of the virus. So even though yes, the majority, like I think it was like close to 80% of those who were eligible were vaccinated, that only represented about like 55% of the overall Israel population because their population is so young. So all of these things, that were discussed before, and this other point is why we're seeing what we're seeing in Israel, and it's not because the vaccines don't work.
All right, thanks. Dr. Mackenzie, there's a question for you. Someone said that the mom has hypertrophic cardiomyopathy. Should they take the vaccine? Or can they? What advice can you give in relation to that? You're on mute.
I'm sorry, can you repeat that? I missed it.
The person said that the mom has hypertrophic cardiomyopathy, And what advice can you give them in relation to being vaccinated?
They should definitely get vaccinated if you have hypertrophic cardiomyopathy, because you fall that their mom will fall in the high risk group, meaning that their mom will have a higher risk of getting hospitalized, having severe complications, and dying from COVID than everyone else. I just want to go through what is called the high risk group from COVID-19 is people with cancer, people with a history of stroke, people with chronic kidney disease, people with COPD, lung disorders, people with diabetes type 1 and type 2, people with Down syndrome, heart condition, which includes cardiomyopathies and heart failure, HIV patients with neurologic conditions such as dementia, multiple sclerosis, for instance, people on immunosuppressants, HIV, people who are overweight or obese, women who are pregnant, patients with sickle cell disease, people who smoke cigarettes and weed. Yes, if you're smoking weed, you count. People who have a history of solid tumors or blood stem cell transplants, and then people with other disorders such as cystic fibrosis and thalassemia. Additionally, if you have any disorder that requires you to take immunosuppressants, including but not limited to steroids, you're considered high risk. So for everyone everyone who's asking, if anyone you know falls into that group, they are at the highest risk of dying from COVID. They're at the highest risk of having no morbidities from COVID. And these are the people that should be vaccinated the most.
I think just to add to Dr. Mackenzie's point on those high-risk group of people, I mean, in the UK, we had these people shielding at first, and they were actually given the first phase of the vaccine. All of the people that have been mentioned by Dr. Mackenzie, all of this group, that group of people, so it's absolutely imperative that people get to find out from their doctors if they belong in these high-risk groups and get vaccinated. There are very, very few cases that people who don't require the vaccine. Very few. Most people who are in that high-risk group will require vaccination.
Dr. Moses, if someone contracted COVID, how soon after can they be vaccinated?
The recommendation is like 10 days. Once the acute phase is over, you should be good.
So 10 days after they recover, basically, from the infection. Okay, here's another one for you. If a child has asthma, can she be given the vaccine?
Yes, and back to like Dr. Mackenzie's point, if that child has asthma and she gets COVID-19, she is at a huge risk of respiratory distress, respiratory failure, huge risk of like ending up on a vent for something that's like totally preventable. And that's why I would recommend like a vaccine for those sort of patients. And not only asthma, but patients with like COPD, cystic fibrosis, and any other underlying pulmonary conditions.
And just real quick, if your child is over 12, it's not approved as yet for people under 12. So if your child is over 12 with severe asthma, they should get vaccinated. But there's a lower limit. There's no upper limit. So if your grandfather is 98 and has diabetes or kidney disorder, he needs to get vaccinated.
Okay. Can someone be reinfected with COVID-19?
Yes, you see it. You don't see that often. You see it like every now and then. Sometimes the second time you get infected, it's like less severe than the other time. You do see from time to time. For the entire year, I've seen it like about 3 times.
It's rare.
With regards to that, it depends on the strain. So most likely, the alpha strain, for example, very early on, the Cleveland Clinic looked at a few people, about 1,000 or so people, not a lot. And they found that these people were unvaccinated, got infected with the alpha strain, and they never got reinfected. All right. So there was some idea that with the alpha strain, that if you got it once, the likelihood of you getting it again was quite small. It was that wasn't reflected with the Delta strain, however. In fact, the Public Health of England had a study that was published that if you had it within like less than 180 days or so, you're about 46%. You have a 46% chance of actually being reinfected with the Delta strain. So it depends on the duration of how long you've had it. But the answer to the question is yes, you can get it, and no in some ways.
Okay, now this one is for everyone on the panel here. There has been strong arguments about the use of ivermectin and hydroxychloroquine as a treatment protocol as opposed to vaccination. I'm conflicted as both sides appear to have strong arguments. Can you explain more about these methods, both the pros and the cons, and why vaccination is better than using those other treatment protocols?
All right.
You want to take this one? I'm sorry, go ahead.
I want everybody to take that one.
Let me clear the air on this, right? And I know this is a very controversial topic, and I don't want to step on anyone's toes, so I'll be as diplomatic as I possibly can. There is the evidence for ivermectin is still hanging in the balance, all right? There is no conclusive evidence that suggests that it works. No. When this started about sometime last year in spring, going into summer, there was a big hype around something called hydroxychloroquine, which is an antiparasitic drug, which was supposed to block the entry of the virus into the cell. All right, that didn't have much of a that was flavor of the month, and then it died. In its place came ivermectin. Now, ivermectin, initially there was some research done around it, and they suggested in vitro, so which means that they've never actually done it in real life, but they've put COVID cells and given them ivermectin in a petri dish and found that they didn't survive. They didn't replicate, all right? Now, the dose that they have given of the ivermectin in the petri dish was quite high. It's not high. It's actually a toxic dose if it was going to be used in humans. However, it was still quite promising. Now, fast forward a year later, a guy called Andrew Hill publishes a meta-analysis which basically looked at about 12 different RCTs, random control trials, all right? And in those random control trials, you had about the 12 of them, you had about 3 of them that were actually peer-reviewed. One of them that were actually peer-reviewed, when you put all the RCTs on a forest plot Nick, you would know a forest plot much better than I do, but a forest plot is an aggregate of all the studies that were done using ivermectin. And actually, one of them that were actually peer-reviewed didn't actually it didn't show any difference. So basically the control was actually better than the ivermectin, all right? And the 2 other studies that were pushing ivermectin quite heavily was a study that was done in Iran and a study that was done in Egypt, all right? Now, the problem with those studies is that they weren't initially peer-reviewed, but they were on the preprint. So you could actually pull them up and look at them. But not everything needs to be peer-reviewed before it's acceptable, right? We have vaccines that have been used before they've been fully authorized. And I could accept that. But when that data was actually reviewed, it actually showed that a lot of the data was manipulated, all right? So what does that suggest? No, I'm not going to say ivermectin doesn't work. If you want to use ivermectin, that's entirely up to you. I'm not going to take that away from you or anybody else. However, ivermectin is not recognized and as a use to treat or to prevent COVID-19. I'll say that one more time. It is not recognized as a form prophylactically or in treatment. And that is not just me. That's not my opinion. That's what is reflected by the FDA, the CDC, the WHO, the NICE guidance, and we don't even bother using it in the UK, even for what it's actually supposed to be used for, So there's no evidence so far that it works. If people are using their own cases just to suggest that it works, that's fine. If they want to use a couple hundred people and so on in communities, and people want to run the risk of doing it and saying that it works, then maybe it does. I'm not saying, I can't tell people what they feel, but there is no conclusive evidence that it works. There is conclusive evidence of all the data that I've given you to suggest that vaccination helps reduce severe COVID. I'll let someone else take the floor now. I think I've had enough.
I'm gonna say something quick about ivermectin. So this is the tricky bit about ivermectin, because I took the time to actually review the data on the ivermectin and see where it came from. So what happens is that there is a type of worm called the threadworm or Strongyloides, and in places where that parasite is endemic. Not Grenada. This is places like South America, so see people like El Salvador and places, or places in Africa like Zaire, where they have a very high cases of Strongyloides. When these people get COVID-19, they can get super infections from the Strongyloides, meaning that the immunity drops and the Strongyloides actually gets worse. So these people were treated with the ivermectin, and the ivermectin treated the Strongyloides. It did not treat the COVID-19. So unless you're living in a geographical location where there is strongyloides or the threadworm, and I guess the vets in Grenada could tell me whether that's something that's common in Grenada, but I don't think it is. There is zero benefit for giving ivermectin because ivermectin does not treat the COVID-19. And this is not my data. This is the data that is reported, and there's countless studies supporting that. The people who are at increased risk of getting threadworm are people that live in the areas where it's very common, which I don't think it's common in the Caribbean. And these are the people who are farmers, who are exposed to contaminated soil. And if you're not a farmer in Zaire, ivermectin will not help your COVID-19.
All right, thanks. Anybody else want to go ahead?
I think one perspective, y'all have covered the science really well. So I'll give this perspective. I think, there's a reason why we use randomized controlled trials when we are determining the safety and efficacy of drugs, right? Because it's very important to make sure that what we're putting into our bodies are safe. And randomized controlled trials are what we consider gold standards. And not only do we use that type of study to do this, but we want to make sure that we have tens of thousands of people in those studies and people with different health statuses, so that we really can see what we see from these studies, can we generalize it to the greater population. So I think we have to be very careful when we have, a couple, 10 cases or 100 cases, and we say this has worked. We don't know that it's worked, right? It's kind of like earlier on in the pandemic in Grenada when we were saying, everybody's recovering from COVID. We have not seen enough numbers to have said that. And it's really important to have data on a lot of people, and it's really important to look at studies that are designed really well and have the power to say that something is safe and that something is effective. But I think, the folks before me have covered the science really well, but ultimately, the point is this is not approved for the treatment of COVID, and it's not approved for the treatment of COVID because it just hasn't held up in the case of hydroxychloroquine, did not hold up in a randomized controlled trial, which is why the FDA revoked usage of hydroxychloroquine last year for a subset of patients.
All right, thank you. Another person asked, why can I not just do the steam regimen and take the bush tea or the bush medicine? All right. The person said they have bad allergies, shellfish and peanut. Still, should they still get vaccinated? They're afraid of having an allergic reaction. What kind of long-term side effects did you see patients get from COVID?
Well, I think it's too early to tell about any long-term side effects because vaccines just has not been around long enough. We do see patients with some mild reactions. Usually they have a fever, a little body aches, headaches, some nausea, vomiting. The only serious reaction I have ever seen personally was a patient with multiple sclerosis, and multiple sclerosis is an autoimmune condition. And a day or so after he got the vaccine, he had what you call a multiple sclerosis flare, where he couldn't walk, he couldn't move his arms. Fast forward a couple days later, he was admitted, and we gave him steroids, high dose steroids, and within 2 days, he was better, back to baseline. And I would argue that yes, the effects for him, the side effect of the vaccine was severe for his case, but I would argue that if he actually got the COVID, considering that his multiple sclerosis is so labile, if you got that patient on a vent, it would be almost impossible to get him off of the vent.
I'm going to try to answer that as well and add to a bit of what Chad said. So if you want to do steaming, there's nothing against steaming. You could probably steam your life away. My mom, and so they'll do steaming even if they've had the vaccine, right? So, but steaming shouldn't be a substitute for the vaccine. So the person mentioned the fact that they're allergic to shellfish and so on. I mean, I think that's one of the advantages that we have with with these RNA vaccines is that you don't actually use mammalian cells or embryonic chicken cells, so on. So, which is what are sort of conventional vaccines that we use for, either in an attenuated form or inactivated form, or sort of an antigen form, right? So those were the things that would have come with those vaccines. With an RNA-based vaccine, which is what Pfizer is, and the AstraZeneca is not purely that, but it's a bit of a DNA and an RNA combined. But those vaccines shouldn't give you the effects that you would.
All right. It seems like Dr. Lambert is frozen. No.
It's okay.
I wanted to.
I don't know if you guys hear me.
Oh, I'm sorry.
Oh.
Yeah, we hear you.
I could talk about the some of the side effects of the vaccine if you don't mind. Can you guys hear me clearly?
Yeah, go ahead.
Hello?
Right. So there are three main side effects that are from the vaccine. Now, there's a lot of things that are associated around the time people get the vaccine, but we keep in mind that there are hundreds of millions of people that have gotten the vaccine. The major side effects, well, I won't call it major, but the side effects that people are concerned about are the thrombosis, which is blood clot, thrombocytopenia, which is increased risk of bleeding, and myocarditis or pericarditis, that's inflammation of the heart. I know a lot of people saw that, and Guillain-Barré syndrome. Now, Guillain-Barré syndrome is basically a weakness that people develop. So let's go through the numbers. So let's start with thrombosis, which is increased risk of blood clots, and let's talk about thrombocytopenia, which is increased risk of bleeding. And let's talk about the vaccines where you can see that. You can see that in the AstraZeneca vaccine, you can see that in the Johnson & Johnson's vaccine, and the incidence of either in any of those vaccines is 3 in a million. The Grenadian population is, 120,000. So the chance of someone in Grenada having a side effect of that is very low. And as I said earlier, if you do get COVID-19 where you need to be hospitalized, your risk of developing a blood clot is about 33%. So 33% versus 3 in a million, which is 3 in a million translates to 0.000003%, which is getting the clot from the COVID-19 increases your risk 10,000 times that of getting a clot from the COVID vaccine. So there's that. So that has been reported. Let's talk about the myocarditis or the pericarditis, the inflammation of the heart. That can occur in the Pfizer vaccine and the Moderna vaccine. What they found is that the rates in women over the ages of 30 is 2.4 cases per million. Again, the Grenadian population is about 120,000, so divide that by 10, I guess, or maybe even more, divided by 10. So the chances of you developing that in Grenada with a population of 120,000, if you get the Pfizer or the Moderna vaccine, is probably about 0.2%, probably 0.3% chance. And if you are the highest rate of myocarditis, inflammation of the heart, we're actually seen in very young men, and that was about 40 cases per million. Now, the myocarditis was treated with NSAIDs, which is like ibuprofen. Less than, I have the numbers right here, less than 2% of those people who had it required steroids or IVIG. They really got ibuprofen, went home, and they did better. All right. The other side effect of the vaccine is the Guillain-Barré syndrome. And Guillain-Barré syndrome is basically, it's a disorder where you get the vaccine and you have this diffuse weakness. Most people won't get that. The people that get it are the people who've had Guillain-Barré in the past. If you haven't had Guillain-Barré, the chance of you getting Guillain-Barré is extremely low, and the incidence of that was 7 cases per million. So Grenada has a population of 120,000, maybe you can divide that by 10. The chance of you getting that, if you get the vaccine in Grenada, is probably 0.78%, one less than that. So, well, even much less than that, actually. Sorry, forgive me, all the maths teachers who are on. But it's a very low risk. And these are the only 3 things that are generally associated with the vaccine: clots, myocarditis, Guillain-Barré syndrome. And the incidence of that, if you get the vaccine, your chance of getting that, the chance of someone in Grenada getting that is less than 1, right? if everybody going to get vaccinated, less than one person statistically will get any of these symptoms.
Okay. Thanks.
Keston, can I? Sorry, I just want to bring in the public health perspective on this too. I get people's perspective that, you know, like if I boost my immune system, if I'm healthy, I'm good. But I just want us to remember that this is a virus that is spread to other people, right? And if we think, you know, data may suggest otherwise, that, you know, you'll boost your immune system to a point where if you are exposed to COVID, you would not get infected. That would not happen with everyone, right? And if we think if we are healthy and our immune system is really robust, that if we do get COVID, that we are going to recover, we'll be fine, we're not even going to get that sick, we have to also remember that once we are infected, we can spread it to other people. And there are many people in Grenada, you know, thinking about our diabetes rate per capita, our asthma rate per capita. There are a lot of people who are high risk for severe COVID. So I think, you know, when the steaming and any other means of like trying to boost your immune system is obviously very important, but it's also like an individual protection, right? And the reason why, you know, many of us, or I would say like, I think people should get vaccinated and that we need to focus on other mitigation efforts is because there are people who, no matter if they steam from here to tomorrow, or if they try any of those things, like they're not going to boost their immune system to a point where if they do have COVID, that they are going to A, survive, or B, prevent really serious illness. So we have to think about the fact that like we are all sort of like in this thing together. And it's not only necessarily about you and what your outcome is going to be if you do contract the COVID virus.
And I'll make one more point and then yield the floor. So a lot of people, you know, we have this belief that, yeah, you know, if you get COVID-19, there's a high probability that you're going to respond and you're going to recover. True. However, people that recover from COVID-19, they also have long-term side effects. As I said, people who will get sick with COVID-19, there are increased risks of heart attack, stroke, blood clots, kidney failure, you know, severe pulmonary scarring requiring them to be on oxygen, social issues, PTSD. So it's not just, oh, I get COVID and I do dead. It's, oh, you know, you can survive and then you have to live your life with the complications of the COVID. We have to think of that as well.
Okay. Someone asked me a question recently. Now, the young lady said that after she took the vaccine, she saw a change in her menstruation. Like it started coming irregularly when it's supposed to come, it did not, and then unexpectedly came. Is it as a result of the vaccine, and would it be long term, and what problems would she have with that? So we have seen, like anecdotally, a lot of women have commented that after their period after getting vaccinated has been either late or it's just been irregular in terms of like the intensity, like it's been like a heavier period. And so, sorry, I had some feedback. So while that's a side effect that has not been assessed or like monitored, but there are a lot of researchers that are looking into that now. The good thing is that from all of the information that has been gathered from women in the United States in particular, and I think it was over 100,000 women, this was short term. So it only happened the first cycle after being vaccinated, or at most the first and second cycle after being vaccinated. And there, you know, there's an idea that the immune system could play a role in the buildup and breakdown of our uterine wall. And so that's why potentially there have been differences. But again, you know, there hasn't sort of been like a routinized way of looking at this. There are people that are looking at it now, but two, you know, it's really looking like it's short term, and it you know, it hasn't been like something that's
ongoing, at least for U.S. women who have been vaccinated earlier in the year.
Okay, thank you. Now, there is another question, menstruation on the side of women. Now, someone wants to know if the vaccine can make you sterile.
No. Fake news.
Short answer.
But there have been people who have reported menstrual irregularities with it. That's just prolonged bleeding with it. And so in the UK, we have the UK card. So I think you guys have the VAERS in the US, but we have the yellow card where you report the side effects of it. And that has been one of the minor side effects that have been reported by a few hundred people, menstrual irregularities. There's been no side effects from the millions of people who have received it in the UK are complaining of. I've looked at all of the yellow card complaints, and none of them have included sterility, but certainly menstrual irregularities, yes.
All right, thanks. Now, another question here is someone wants to know, is natural immunity out the door? I know there have been cases where people saying that the vaccine has been pushed more than herbs and stuff. And if you would have tested positive for COVID and you've recovered, you would have natural immunity. Why should you be vaccinated after all that?
Well, like as I said, I think it depends. The thing is, I agree in some ways, because that was one of the questions I think everybody has had earlier on regarding COVID, right? Whether or not I need to have this vaccine, because if you have a child and they send them to school, they get chicken pox, you're like, thank God they get chicken pox. I don't have to deal with chicken pox again in my life. And you're probably right, okay? If you have the flu, however, you could probably get the flu different. In the same flu season, you could probably get different strains of the flu and get it again. So this is what happened with COVID, that the architecture of the disease, the architectural immunology of the disease is not very well understood. There's no experts in COVID. So we're all kind of playing it by ear. And as I've said, there was a Cleveland study that looked at about 1,000 people who had the alpha strain, and they didn't get reinfected. So certainly innate immunity conferred something onto those people. That's what we're hypothesizing. Whether or not this is actually accurate, we don't know, but that's what we believe the data is pointing towards. However, we didn't see that with the data from the Strasbourg. I was pointing out the Strasbourg cohort, which looked at how the antibodies actually got neutralized with the Delta strain. And you actually fear that people who actually had needed a response dose actually needed one of the AstraZeneca or the Pfizer vaccines to get to the ED50, which is the level that you need to have to provoke or evoke any sort of biological response from the virus. So the answer to the question is not clear cut. It's not yes or no. It's still yes and no from the data.
And there was a small study in the U.S. that saw that people who are vaccinated compared to people who are not vaccinated had a lower likelihood of getting COVID a second time. So it seemed like getting the vaccine gave them more of a robust response, that they were not becoming infected with COVID a second time compared to someone who had natural immunity. They got COVID but did not get vaccinated after getting COVID. But that was a smaller study. But that sort of points to a reason to be vaccinated, even if you already contracted the virus and may have antibodies that can protect you from a second infection.
Okay, it's interesting. I have another question here. Someone said my daughter has had rabies recently. They got the vaccine for that, and how soon after can they get the COVID-19 vaccine? Should we skip that? Yeah, I'm waiting for a very good answer.
I mean, I'm surprised they had rabies and they survived. I mean, that's impressive in and of itself. The answer to the question is I don't know. I don't know if Chad has encountered that in ED before. I have never encountered that. So I don't want to give you an answer because I don't know.
All right.
I will say, at the health department, New York City Health Department vaccination sites, that if this was for any vaccine, not necessarily rabies vaccine, if you had a vaccine in the past 30 days, we were not vaccinating you. But
Okay.
I mean,
that's just sort of like the
regional, but
protocol there.
The rabies regimen also has like the antibodies and stuff. So that's going to complicate it even more. I don't have an answer.
All right. Well, I guess we couldn't
You
have
can
that
look it up
person
and
next time.
yeah.
All right. Now, there is another one that I've been seeing a lot where people say that that flu, influenza, and COVID-19 is the same. And when you go to test, that basically if you have the flu and you go to do a test for COVID-19, it will come out as positive.
Completely incorrect. 100% incorrect. The
So then,
influenza.
tell us the difference between those two, please.
Right. So the influenza the flu is caused by influenza virus. Right? COVID is caused by coronavirus. Just in the name alone, they're two different viruses, and they can be differentiated by molecular testing. Actually, so when COVID originally started running rampant in the United States, patients that came in with flu symptoms, they would recommend that they treat both for the COVID and the influenza. But once the molecular test confirms or refutes whether the patient has influenza, then you start the treatment for the influenza. So clearly those are two very different things. Flu, influenza, COVID-19, coronavirus, different.
Apart from just sort of from an infectious point of view, even from an epidemiological point of view, if you look at the reproductive rate of the two, they're very different, right? So when we looked at the alpha strain, the initial period was about 2 to 3 days or so, whereas in the delta strain is 5 to 9, and I think influenza is about the same period as well. The series interval, which is basically the time that an infector and an infectee will show symptoms, are very different as well. So even from that standpoint, they're not really the same. So I know what people are thinking. It sort of manifests itself in a cough, and I'm bedridden, I have aches, and I feel bad, and I want to drink something. Yeah, but in reality, they're not the same. The outcomes are not the same. For example, if you look at the long-term effects of COVID, you don't really see those long COVID, which gives you a kind of a similar presentation as someone who's got polymyalgia or chronic fatigue. You don't actually see that with the flu. On imaging point of view, again, you don't see the same things that you would with the flu. You probably get more of an atypical thing on an X-ray and even on a CT if you look at someone who's got COVID. And so they're not the same thing. They're not the same thing. But to the eyes, it looks like pretty much the same thing, but they're actually not.
Okay. Now, a person with a history of severe allergic reactions to vaccines, should they get vaccinated?
That is something they should consult with a physician about. The composition of the mRNA vaccines that we have now is like way different from the traditional vaccines. So theoretically, you probably would not have much of a reaction, but like allergic reactions are serious. So I think it's upon the person to have a good discussion with their primary care provider.
Okay, so for example, someone has a history of DVT, right? Would you suggest a vaccine that they should take and one they should not, or would you tell them, okay, maybe you should stay away from vaccines altogether? I mean, because I know someone who has a fear of being vaccinated because they heard of the blood clotting and stuff.
That's a very good question, and that's a question I get all the time. If you had a history of blood clots, the first thing we have of DVT or PE, but I'll just say blood clots because it's easier, and most people will understand that. If you have a history of a blood clot and you're on a blood thinner, you can get a vaccine. If you're concerned about the risk of vaccines, the risk is extremely low for the Johnson & Johnson and the AstraZeneca. So if you have a history of blood clots, you're concerned, get the Pfizer vaccine. There's been no risk associated with blood clots in the Pfizer vaccine that we're aware of. But you should definitely get the vaccine if you have a history of blood clots.
I mean, in the UK, the MHR rate, because that was a big thing, because the AZ vaccine was really from the UK, we had over just about 150 or so blood clots that were reported between last year and up to September, the first week in September of this year. About 17% of them actually resulted in a fatality, all right? And the majority of these cases were actually after the first dose of the AZ vaccine. But still, when you look at the numbers, it really stacks heavily in favor of you taking the vaccine, as Dr. McKenzie accurately pointed out. If you get severe COVID, you're at 33%. If you run the risk, if you have a history of DVTs, and you were talking about 2 to 3 cases per 1 million doses, right? So literally, you're talking of about less than a 1% chance, less than a 0.1% chance versus a 33% chance. You don't have to be a mathematician or a statistician to say that, where am I going to roll the dice?
Okay. Now there's
another thing. I don't, just for the viewers' sake, and I don't mean to take away the seriousness from this, but just FYI to anyone who's commenting about bush tea and all that stuff. Please feel free. You wanna drink meringue, beta fence, drink beta fence. You wanna drink whatever you wanna drink, whatever you wanna steam, that's fine. But please, strongly consider getting the vaccine. Strongly consider doing the physical distancing. Strongly consider wearing your mask. We don't care what you do at home. We don't care what you drink at home. Because the vaccination is not just a solely it's about me situation. Vaccination is, yes, I protect me, but I also protect the people around me. And I also help the nation get back to a sense of normalcy. The longer coronavirus runs rampant in Grenada, the longer it's going to take to get back in the position of normalcy. And in terms of the world economy, if Grenada isn't moving forward, it's just moving backwards. So if you think, I'm not going to get the vaccine, I'm just going to drink bush tea, that's okay. But the longer Grenada takes to recover because of the low vaccination rate, the more you're going to suffer, and your kids are going to suffer, and the people around you are going to suffer living in the country in the longer run. That's just because I know a lot of people asking about bush tea and herbs. Take your herbs, any herbs. I'm fine with that. Just take it and get the vaccine at the same time. They're even better.
So there's no possibility of the clashing or any effects of the herbs and the vaccines mixing, basically.
No, there's no contraindication. There's no effect with the vaccine on any herbs. I've checked. I've had a lot of patients come with a list of every single herb, every single type of everything. They've come with everything. I've had people, I've had to research herbs, and so far I haven't found any herb that interacts with any of the vaccines. Trust me, it's exhausting.
All right. Someone asked a question. They say that they seem to be confused about the term herd immunity, and they're hoping that you can explain herd immunity to them, and if it's a possibility in Grenada based on how we're seeing with the vaccine uptake and everything. Dr. Moses, you want to take that?
Well, the whole idea of herd immunity is to have enough patients in the population vaccinated. So if one person gets it and he goes to spread it to that person here will be vaccinated, so he won't contract it. The ideal number for herd immunity is 70%, or above. With the current vaccination rate we have in Grenada, I think it's 17,000, maybe it's a little bit more right now. We're nowhere close to that.
Yeah.
Okay.
So with the recent rise in the cases in Grenada, if we had a robust herd immunity, you would not have had that rampant spread. What would have happened? You would have had a few people get it. And you would have pockets, pockets of outbreak here, pockets of outbreak here. But because we didn't have the herd immunity, it just spread like wildfire. That's the whole idea behind it.
Yeah, and just to add to Chad's point, herd immunity is closely related. I think Nikki might know this better than I do from epidemiology. There is a relationship between the R number and herd immunity. I don't even remember the exact mathematical formula, but essentially what you really want to do is get the R numbers down. Getting the R numbers down, getting more people vaccinated. Because what that will do is that to get to that point, you don't just get herd immunity. You get herd immunity by getting people vaccinated. You don't just get herd immunity by having 5-10% of the population vaccinated and then letting the rest of them run wild. It's not the idea. That's not the idea behind it. The idea behind herd immunity is driven by vaccination and a combination of people just interacting. But you don't get that if the numbers are too high, if the R numbers are too high, and you don't get it if the vaccination numbers are very low. Plain and simple.
Okay. Now, in terms of, there are people who say they rather take the chance of getting infected with COVID and getting natural immunity. Now, can you explain the argument natural immunity versus immunity from the vaccine? If you already have natural immunity, why do you need to get vaccinated? Wouldn't the natural immunity be long-lasting?
If you get natural immunity by contracting COVID and you survive, it's all well and good. But you also have to think about the long-term complications of COVID itself that we already talked about. So it's like a risky way of getting natural immunity versus just getting vaccinated, where the risk is much lower.
Okay.
Also, you're looking
ahead.
at the environment that you want to get it in. If you want to run the risk of developing severe COVID and going up to an ITU and being in a queue for ventilation, that's entirely your call. Or being on, having to have non-invasive, ways of getting oxygen. That's not something I think you want to run the risk on doing. But everybody makes their own decision. I think if you look at the facilities in Grenada versus to what you see in high income countries, which, I mean, we were struggling for beds. The decision on who to place on ventilators was it was ethical, it was moral arguments were put forward. I don't think you want to get to that point. I really don't. This is what I mean. I think the gravity of what we saw in the UK is not what I would like to see for my people, because I just don't think we have the capacity to manage that.
You don't.
And that's what I fear, that people have not, they've seen the television, because while we were going through the pandemic in the UK, I mean, literally it was shut down. I mean, this country was on its knees, and Grenada was happy. Grenada didn't have any cases then. There was nothing, literally nothing going on in Grenada for a long time. We were seeing thousands upon thousands of cases per day, deaths in the hundreds. I mean, it was really scary when we had our first phase of the virus. And I mean, if you look at what's happening in Grenada, for example, in the last 14 days, 12 to 14 days, we have a case fatality rate now almost of about 3%, which is where we were. So that is scary enough as far as I'm concerned, because you don't have the support in Grenada that you have here or in the US. You don't have the human resource. I mean, we were short of doctors, we were short of nurses, we were short of, I mean, they had to expedite and coerce people into making ventilators. We don't have that kind of resource in Grenada. I just don't understand why run that risk when you have a vaccine there.
Okay. What about in terms of having to decide? There is somebody like an older person, a younger person, and you have there is a need for ventilators. And I know when you get to the ventilator stage, it's probably a late stage in the infection. Now, and I'm coming to something in the sense of ethics. Do you guys have to decide who gets that ventilator, who gets that treatment based on factors, or do you ignore that and you just wing it?
So first of all, that's a very provocative question.
Yeah.
Could get us some problems for that. But not all 70-year-olds are created equally. You have like some 70-year-olds that have a physiology of a 50-year-old. I think what would be the most reasonable thing to do is to look at both patients and figure out who has the best prognosis. If you have a 70-year-old and he was just put on a vent, he doesn't have like any online medical conditions like hypertension, diabetes. He doesn't have any primary lung disease like COPD, versus you have like a 40-year-old who's an alcoholic, cirrhotic. He's on the organ transplant list. The answer would be pretty clear. So long story short, you look at a person who has like the best long-term prognosis, and I think that's a person we will tend to give the vent to.
So you're saying that you consider all the factors and then you choose somebody. You choose the person who most likely have a better chance.
Most likely to have a good outcome after being extubated, after coming off of the vent. and surviving it. You know, you sometimes a lot of times you
I'm
have
sorry,
like
I don't mean to interject, but you know, I have to. A lot of people believe that doctors are just running around and just making the decision, deciding who lives or dies. That is absolutely not how it works. Every hospital in the United States has what we call an ethics committee. Right? Every hospital in the world should have an ethics committee, and it's the ethics committee that really makes the decisions that says, okay, listen, guys, this is the resources that we have, and this is the resources that we have, and we have to make a decision on who are the patients that has the best chance of recovering, and we have to funnel the resources to these patients because this is where it could have the maximum benefit. It's not just the doctors just running around making these decisions. I just had to interject. I'm sorry, Dr. Moses.
No, you're good.
Agreed.
All right, thanks. Yeah. Can you mix vaccines? Because someone said they took the AstraZeneca first dose, but with all the information about it and blood clots, they're afraid to take the second dose. So can they get the Pfizer?
I honestly, that question was raised before. I mean, in theory, if you look at how both of the vaccines work, it really shouldn't matter, but I don't know. Because at the end of the day, what both of the vaccines are doing is essentially, producing an antigen that the body can recognize and then code antibodies and provoking a T-cell response from it. Both of them, right? They're just doing it. They get into that endpoint in different ways, but that is ultimately the endpoint. In theory, maybe, but I don't know of anybody who's done it.
Yeah, I think it's all theory at this point. And in the US, with all the conversations around the booster shots and the recent recommendations for booster shots, there is conversation around potentially giving a Pfizer booster shot to people who received the Johnson & Johnson one dose vaccine, but a decision hasn't been made yet. So I don't think I'm not sure that any regulatory body has necessarily endorsed mixing the vaccine as yet, though as Sean said, in theory, it should not make a difference, but it's not recommended yet.
I mean, because initially what they went against, if you remember, like when we were rolling out the AstraZeneca and the Pfizer's, I mean, the duration was different. I think AstraZeneca, you were supposed to, I think it was Pfizer, was within the first 21 days you should have both of them administered. And that didn't happen. And the JCVI, which is the sort of the Joint Vaccinations Committee on Immunization, looked at it and they said there wasn't any reason why we couldn't extend it because they wanted to get more people at least have the first dose. But that's with the same vaccine. With different vaccines, I don't know. I think if you've had one, my advice would be to stick to it. And with the statistics that we've given you with the risk of clots, I would just probably go for the same vaccine.
Okay. Should we consider bubbles in Grenada right now?
You mean like plastic bubbles?
Bubbles, community bubbles.
What do you mean? What was that? Like
how you had bubbles in the UK, little bubbles, so you can only be around a certain subset of
I think you mean the decentralization. So you mean like you have places that are marked out. So okay, this is an area that is like, let's say level 1 to 4 being the place with the most COVID cases, 1 being the place with the less COVID cases. So you demarcate it. So you'll say, okay, for instance, this place has a large population and it has a lot of incidence of COVID, so there'll be a level 4 bubble. Whereas this place has very low chance of COVID or very low COVID cases, so it'll be a level 1 bubble. That's what you mean?
No.
Do you mean like in the US, like I know we had pods. So people selecting like, these are the 10 people that I'm going to interact with. My kids are only going to interact with these 10 people. Why not? But I think at this point, I would encourage people to try to stick to the folks in their households as best as possible, and reduce like any unnecessary interactions with people outside of their households.
Okay. All All right. Thanks very much for that answer. So, from a public health and a epidemiological standpoint, the social distancing measures, right? We are trying to implement them, but why get vaccinated if we're doing those things? If you're saying physical distance, wear your mask, keep your 6 feet and those stuff, then why get vaccinated? Why should people get vaccinated?
Yeah, I think Sean said it. I think Sean said it, alluded to this earlier, right? Like right now, our vaccination rate, I think, is 30%. Great. We're getting up there. But that means that we have 70% of our population that are unvaccinated. And as all of the data that I think all of us here have talked about, throughout this discussion has shown that, among people who are unvaccinated, the virus tends to spread more and there's more severe cases, right? So being vaccinated does not completely eliminate the context in which we're living in, which is that we don't have herd immunity. We only have a small proportion of the population that is vaccinated. I think when we get to a point where, we have more of a herd immunity and we don't have so much spread going on, then we can talk about taking out those secondary mitigation strategies. But at this point, it's still possible for you to get become infected with COVID, though that risk is low. And if you do become infected with COVID, if you are vaccinated, you can spread COVID just as much as someone who's unvaccinated. So we have to sort of be, as careful as possible. As I said before, just making sure that we're dotting all of our I's and crossing all of our T's. It's not because the vaccines are not effective. It's because of the context that we're living in, which is that most people are not vaccinated on the island.
All right. Dr. Moses, you wanted to add something, I think.
No, she covered it all.
Okay. All right. Well, the thing is, we can go on and on, but sadly, we've come to the end of our time. I want to thank you guys for taking time out of your busy schedules to be here to answer a lot of questions in this series. We've covered basically all the angles in terms of social distancing, natural immunity versus immunity from vaccines, herd immunity, in terms of other medications that you could use. I have one other question that somebody asked. Someone asked about using what can you use to minimize the side effects of vaccines? Is Panadol, ibuprofen, those things, are they good to help minimize the side effects of the vaccine?
Yeah, when I had my first vaccine, I had all of the kind of the side effects. So you felt achy, you felt bad. I felt rubbish. Took 2 paracetamol and I was good the next day. So yeah, you could take it. It'll be fine.
So it's fair to assume that everybody here, well, all of you guys are vaccinated.
Yeah, I'm vaccinated, man. And when I got the second dose of the Pfizer vaccine, I got what I could only describe as a hot flash for a day. It was really a weird sensation, but I was one of the first people in the US to get the vaccine. The Pfizer was approved. I got the vaccine literally, I think 5 days after the Pfizer vaccine was approved. And it was the best, I think it was one of the best decisions I made because, it wasn't just a decision for me. I had a young daughter at home. She was 2, my wife was at home. And, I had to go home and just I don't think you guys understand how bad this thing was. We had to assume that everyone had COVID. My nurses got COVID. People that mentored me got COVID. Doctors I work with died. So when I got the vaccine, the only side effect I have was that kind of febrile reaction, what I call a hot flash, honestly, and it lasted for about a day and a half. You treat that with Tylenol and fluids and some chicken soup, and I was much better and I was back to work.
Okay. When I got the first shot, I was done. I had to drag across the floor. So, I'm good now. I'm walking. So I just didn't grow. I thought that I got like a couple feet, go from 4'11" or something. But anyways, guys, I want to thank you very much. I really appreciate you guys taking the time being here for the first in the series. The next time around, we want to talk to some mental health experts on the social impact of vaccines, of the COVID, because I know as people, we are social beings. We love to be around each other. Socializing is our thing, and the inability to do that for the last 19, 20, 21, for the last couple of years, it has been hard on us. And I think we need some people to talk to understand what is happening, how we can better communicate and maybe influence others to do the right thing to protect themselves, social distance, follow all the protocols. I want to thank you very much. I want to wish you guys a great day, a wonderful night, Drs. Lambert and Mackenzie. Good evening, Drs. Moses and Ms. Belfon Louison.
Thank you. Good night.
Thank you, guys.